Okay, so today we're going to do some upper limb x-ray cases. The first case is a 65-year-old male who was hit by a jackhammer. Who wants to take this case?
Yes, I'll take this case.
Great.
So we've got a radiograph of the right hand with multiple views. So the first thing I noticed is that there's a fracture at the base of the first metacarpal, transverse fracture. Just there's doesn't appear to be any extension into the joints proximally. And I'll check the other views to look for some angulation and so on. Yeah. So it also does look impacted and a bit of volar angulation. So all this would be in keeping with a pseudo-Bennett fracture, so base of the first metacarpal and no intra-articular involvement.
Great, excellent. So tell me about the different types of named fractures you can get at the base of the first metacarpal.
Yeah, so as we said, this one was pseudo-Bennett's. There's also a Bennett's fracture, so that's also so I guess with this fracture it's not comminuted, so Bennett's is also not comminuted, but it does extend into the articular surface. Right,
yeah, so a Bennett's is like a two-part fracture and intra-articular, whereas a pseudo-Bennett's, which is also known as an epibasal fracture, which is this one, is two-part as well, but without intra-articular extension. And what's the third one?
And then there's also a Rolando fracture, so that's when it's more than two parts comminuted and intra-articular.
Great. And are any of them requiring surgery?
So I think Bennett's and Rolando, particularly Rolando, Bennett's possibly as well.
Mm-hmm. I think almost all of them in this area are likely to be surgical, or at least need a surgical opinion, because there's a tendon that has unopposed kind of pull. Do you know what tendon that is?
Will be one of the extensor pollicis. Or,
we'll come back to that.
I'm not sure exactly.
We'll come back to that in a moment. So what else about this radiograph? Is there anything else going on?
So there's an arthropathy that involves the proximal interphalangeal joints with some lytic lesions.
So what kind of arthritis do you think this is?
Given the distribution, I'd be favouring more of a rheumatoid arthritis.
Okay. So rheumatoid you're correct, like it can involve these joints, although it tends to be more metacarpophalangeal joints and the carpal joints, and particularly the ulnar styloid can get eroded, whereas this is more interphalangeal joints, and there's quite a bit of bony proliferation around the edges of the joint, whereas rheumatoid arthritis, it's very osteopenic, not much bone, no new bone is being formed, and you get these ill-defined lucent erosions. This has a typical kind of appearance to it. Do you know what that's called? This kind of appearance here. So this is the gull wing kind of appearance. So it kind of looks like a seagull flying towards you, like my daughter would draw if she was drawing a picture. So that's typical of osteoarthritis. And in some forms of osteoarthritis, you can get this form called erosive osteoarthritis, and that classically forms these gull wing appearances. So there's kind of asymmetric loss of joint space. You can see here there's joint space loss on this side, less joint space loss on the other side, and it's involving particularly interphalangeal joints. So this is good for osteoarthritis, and the bone density is relatively preserved, isn't it? It's like quite normal density. Any other finding on this radiograph that you can see that you would comment on in your report?
Just the appearance of what looks like a foreign body over the left proximal phalanx.
Absolutely, yeah. So it looks like it's there on each projection, doesn't it? And so it's most likely actually in the soft tissues there. So I'd definitely be reporting that as a foreign body. This may be something that happened a long time ago and the patient's forgotten about, but definitely you need to be commenting on those things in the report as well. Great. So it's one of those cases that you get in an exam which has an obvious traumatic injury that you need to talk about, but then a few incidental findings that you kind of need to comment on in order to do a good job at passing the case. This is just a summary of those base of first metacarpal fractures. They're unstable due to unopposed pull of the abductor pollicis longus, which is why almost all of these fractures need an orthopedic opinion or a plastic surgery opinion. The one that we saw there was the epibasal fracture or the pseudo-Bennett fracture, 2 parts, extra-articular fracture. A Bennett is a 2-part fracture which is intra-articular, and a Rolando is more than 2 parts, so comminuted and intra-articular. Okay, ready for case 2. So a 9-year-old female with right shoulder pain and swelling. Who's going to have a look at this one?
That was mine, I think.
Go for it.
Yeah, so I think that there is a lytic lesion within the bone.
Which part of the bone? You need to be a bit more descriptive.
And within the shaft.
Yep, within the shaft. And then when we're talking about a pediatric patient, we often use the term, rather than shaft, we might describe it as the diaphysis.
The diaphysis, sorry.
Yeah. So there's a lucent lesion centered in the, or lytic lesion centered in the diaphysis. What else about it?
There's some periosteal reaction.
Yeah, I agree. Here's some here, isn't there? It's kind of ill-defined and interrupted periosteal reaction, but there is some.
Yeah, it looks like the kind of, it's like what they call the onion skin type.
Okay, so multiple kind of layers would be an onion skin type.
Kind of layered.
Yeah, there are some layers. There are other bits that are a bit more sunburst up here. In terms of periosteal reaction, you kind of want to classify it as being aggressive or non-aggressive. Do you think this is aggressive or non-aggressive periosteal reaction?
It's aggressive.
Okay, good. Yep, so there's signs of aggressive periosteal reaction. Getting back to the lytic process itself, how would you describe that appearance in the bone?
So it's kind of heterogeneous.
Mm-hmm. Have you heard the term permeative before?
No.
No. Permeative is kind of like these multiple little holes that you can kind of see in the bone, or moth-eaten might be another term you'd use. These are aggressive forms of lysis within a bone. So this has a very permeative appearance. Another term is zone of transition. Do you know what that means?
Is that when it goes from normal bone to lytic?
Correct. Yeah. So you can either have a wide or a narrow zone of transition. What do you think this one has?
So this has quite a wide zone of transition.
Exactly. Yeah, it's got a wide zone of transition. You can't take out a pencil and say, "Oh, it starts and stops here." You know, it could be abnormal right down to here. It could be abnormal probably right up to the metaphysis here, but you can't really tell. So it's got a wide zone of transition. It's got a permeative appearance. It's got aggressive periosteal reaction. What about the cortex? This is what normal cortex looks like down here. What's happened to the cortex in this area?
So the interruption to the cortex.
Yeah, so it's eroded the cortex as well. Is there a pathological fracture that you can see? I'll give you a lateral as well.
Oh yeah, there is, involving the growth plates.
Yeah, it looks a bit funny up here, doesn't it? This could just be some periosteal reaction, but there may be an actual Salter-Harris fracture through here, a Salter-Harris type 2 fracture. All right. What other features would you describe for an aggressive soft tissue or bone mass like this?
Well, she's got soft tissue swelling overlying.
Yeah, exactly. Soft tissue bulging. You can see how it all bulges right out here, doesn't it? On both sides. Okay, if we go back to the first X-ray, you can see this is much bigger here and much more dense in these soft tissues than you'd normally have. Okay, so all right, we've done well with our description. What do you think the diagnosis could be?
Osteosarcoma with a differential of Ewing's.
Yep, that's pretty good. They'd be the major two, wouldn't they? And in terms of differentiating between the two of those, an osteosarcoma, where are they more likely to be located?
The large bones, like thigh bone,
yep,
femur, or
and they do happen in the proximal humerus as well. What I was getting at is more metaphyseal location is a bit more common for osteosarcomas versus diaphysis.
Okay.
This one is probably involving both metaphysis and diaphysis, whereas Ewing sarcoma tend to be more diaphysis centered rather than metaphysis. So that can help you in favoring one versus the other. And then the other thing would be the matrix. Do you know what kind of matrix an osteosarcoma can have?
I'm not sure.
Yeah, we call it an osteoid matrix. Often this white, fluffy appearance to it. Some areas here might have a bit of white fluffiness, although this is probably periosteoreaction. But if you see white, fluffy appearance to this tumour, then again you would favour osteosarcoma over a Ewing sarcoma. But I think in this case you just need to say this is an aggressive process, most likely a sarcoma. It could be an osteosarcoma or a Ewing sarcoma, and then you'd finish up the case by emphasising how important it is to notify the referrer and to recommend urgent paediatric orthopaedic oncology referral. Okay, because this is the kind of thing we can't leave for very long at all. Here is the MRI for this patient, just showing you the massive extent of involvement along the whole of this medullary cavity right down to the distal shaft, and you can see this big soft tissue component outside of the bone. It's gone through the physis here up into the actual epiphysis as well. So this is much, much bigger than what you actually saw just on the X-ray alone. And I think this ended up being an osteosarcoma. So I just use this case mainly to emphasise some of the words we should be using. Anytime we see a bone lesion, we should be thinking about its location, and in paediatric populations we should be using those terms: metaphysis, diaphysis, epiphysis. We should be looking at the morphology of it. So is it a very well-defined lytic process, ovoid, expansile, or is it permeative like this one? Zone of transition, does it have a narrow zone of transition, which would be a benign, non-aggressive appearance, or does it have a wide zone of transition like this one, in which case that's an aggressive kind of appearance? Is there any internal matrix? If you can see osteoid, new bone formation, then that's useful to identify an osteosarcoma. If you see little ring and arc calcifications, that can be useful because we call that a chondroid matrix and helps you identify chondrosarcomas. Describe the cortical margin, because certain processes will involve the cortex and other ones won't. Look for periosteal reaction, and then classify the periosteal reaction as being either non-aggressive, which is kind of smooth periosteal reaction that you see around fractures and things, or aggressive, this kind of interrupted, ill-defined, often layered periosteal reaction, sometimes a starburst or sunburst kind of appearance. And then look for any soft tissue mass. This one's got a really obvious big soft tissue bulging outside of it. That's obviously a very aggressive feature once you see that. Cool. And then pathological fracture would be another thing to always look for, and because that's often the thing that causes the patient to present to our attention. All right, any questions on that case? So that list of kind of things is what you want to run through. Anytime you get given a case with a bone lesion, you want to list off those things, and it just lets the examiner know that you know what you're talking about, and it means that you're not going to miss anything. Case number 3. So this is a 35-year-old female with right shoulder pain. Can someone have a look at this for me?
Yep, sure. So we're looking at an AP view of the right glenohumeral joint, and most salient finding is a relatively focal area of calcification just around the greater tuberosity and possibly extending to the subacromial area, but probably would want to confirm that with an alternative lateral view or some other view as well.
Yep.
Looks like the cortex is relatively intact, and the glenohumeral joint alignment on the Y view looks pretty good, and also on the superior-inferior view that's got on right now.
Yep.
I think on the laterals it does look like as though it's possibly extending into the subacromial joints or subacromial area as well. So my main considerations for this would be some sort of calcific tendonitis, possibly for the rotator cuff muscles, given the fact that it's overlying the greater tuberosity. I'd also be thinking of calcific tendonitis of the biceps brachii, because that can also happen, but the location isn't really in the intertubercular sulcus.
Yeah, great.
Yeah, so then also be thinking about if there's any calcification within the subacromial bursa as well.
Yeah, can you see this faint calcification kind of coming down here?
Yeah, just overhanging, just hanging over the greater tuberosity.
Yeah, so that's not going to be in the tendon, is it, down there? That's going to be in the actual subacromial, subdeltoid bursa there. Whereas this stuff here, this more amorphous calcium, is going to be pretty much sitting in the supraspinatus tendon, isn't it? It seems to match up with that on all the projections. Great. There is a tiny little bit of bony irregularity here at the inferior glenoid. I'm not sure whether this patient's had a prior injury, but that's not necessarily related to this presentation, I would think. So this is acute supraspinatus calcific tendonitis with associated calcific bursitis. Pretty typical kind of patient demographics as well. You know, middle-aged to young adult female patient seems to be more common. And you get this very much amorphous calcium. You'll often see other calcifications around the greater tuberosity that actually have a cortex to them, so they appear corticated. That's not going to be acute calcific tendonitis. That's going to be maybe some chronic calcification from some other process, an old avulsion or something like that. Whereas when you see this kind of amorphous, high-density material projected right where the tendon is, in a patient with acute pain, this will be the cause of the pain. This is an acute, very, very painful precipitation of... Do you know what type of calcium that is?
I'm not sure, unfortunately.
Yeah, so it's hydroxyapatite deposition. Okay, so you might hear the term HAD, hydroxyapatite deposition disorder or disease. So that's what it is, as opposed to some other different types of calcium you might get, like calcium pyrophosphate is another type. Cool. And they can be treated how, do you know?
I assume usually, depending on how the patient is, you'd try to go for conservative management. But if it's causing a lot of pain and discomfort, is there an option to do some sort of arthroscopic removal of calcification?
Yeah, arthroscopic is probably a little extreme. As you said, you go for conservative first, so like some oral non-steroidal anti-inflammatories. It can be really useful to stick some cortisone just in the bursa to try and dampen down, because often the bursa is where all the pain fibers are. So if you can dampen down the inflammatory response in the bursa, that can do a lot to help the patient. Then the next thing you can do potentially is what we call a barbotage. Under ultrasound guidance, stick a couple of needles into that area of the intratendinous calcium and try and flush some fluid through it and aspirate that calcium out just to reduce the volume of calcium in there. And there is some evidence that can help people recover from this. But yeah, you'd start with the most conservative thing first, but definitely a cortisone injection into the bursa can be very, very useful, because this is a very painful disorder to have, and you can try and reduce the discomfort for your patient. One classic place you'll see this, and it can be very confusing for people, is in the longus coli tendons. A patient presenting with neck pain, there may be a history of some minor trauma or no history of trauma, and you do a CT of their cervical spine, and you'll see directly inferior to the anterior arch of C1, you'll see some amorphous calcification and a bit of prevertebral edema around that area. That's acute calcific tendonitis of the longus colli, and we see a few of those a year, often referred with question mark retropharyngeal abscess from an external site, or thought to represent trauma. So look out for that on your cervical spine CTs, because it can be very useful, and all it needs in that area is just non-steroidal anti-inflammatories and to be left alone, rather than an ENT surgeon going in there and trying to drain a retropharyngeal collection, which isn't really there. Oh, this is the same patient. This is their ultrasound just showing this is the supraspinatus tendon. You can see that hyperechoic focus within the tendon itself, lots of hypervascularity around it, so it's a really inflammatory condition. And then in transverse, you can see here it's getting towards the surface and it's thickened up the subacromial bursa, and some of this has probably leaked out actually into the bursa. All right, so ultrasound is really, really useful for this, both for the assessment of it, but also for the treatment of it. All right, next case is a 35-year-old female, and I have been not very generous and withheld the history for this one. So is someone going to describe this for us? I'm going to zoom it up a little bit.
Yeah, I think this is my one.
All right, go for it.
So, so she's got some lucent Cs in the distal phalanges of the index fingers and the thumbs, and the tufts are actually preserved there, I think. Can't see any fracture, signs of trauma. And the lucencies are quite well defined, like sort of band-like.
Yeah.
I think the term is acro-osteolysis.
Correct, yeah. So when you get any erosion involving the distal phalanx of the hands, distal phalanges, we call that acro-osteolysis.
And I can't see it affecting any other joints.
Just looking at the bones in general, do they look like the normal kind of density of bones that you see, or does there something unusual about the bones in general?
In general, there's sort of increased density, especially around the cortices.
Yeah, they kind of look increased density. They almost look a little bit chalky, don't they? And what I think we're actually seeing is that normally we have quite a good differentiation between the cortex and the medullary cavity, whereas we've kind of lost that in these bones. You kind of can't really tell, particularly in the middle and proximal phalanges, can't really tell where the cortex and the medullary cavity start and stop. And that's actually because the cortex has got an abnormality of it. Can you see these little erosions along the side here?
Oh, yeah. Yep.
Yeah. See that there?
Yeah. And then she's also got some calcification with some soft tissue swelling, which looks maybe it's a site of arteriovenous fistula.
Yes, excellent. Very good observation. This is the kind of thing you get in an exam, and you've got to observe this, and then the whole case starts to come together. So someone with chronic renal failure who's on hemodialysis, what kind of generalized systemic disease can they get related to that which affects their bones?
So hyperparathyroidism.
Yeah. So renal osteodystrophy, a component of which is secondary hyperparathyroidism, and this is the classic kind of hand radiograph appearance of quite severe hyperparathyroidism. You get acro-osteolysis, which can involve the terminal tufts or just the actual distal phalanx itself, and you get this what we call subperiosteal resorption of bone, particularly along the radial aspect margin of the second and third fingers. In this case, it's involving a lot more fingers as well. And you just see that slight little spottiness to the cortex there. So that's subperiosteal resorption of bone. So as I said, particularly the radial aspects of the second and third, middle and proximal phalanges can be involved in that. And then you've got evidence of their renal failure on the film, which is the AV fistula. So you mentioned acroosteolysis. Do you know any other causes of acroosteolysis other than hyperparathyroidism?
Not really.
Okay, we'll come back to that in a moment.
Yeah.
It's worth having a bit of a differential for acroosteolysis. So as I said, hyperparathyroidism, you get acroosteolysis. This is a different patient here, but you can see here the terminal tufts are eroded, so that's acroosteolysis. You get osteopenia, but they say it's osteopenia, but it often looks a little bit whiter just generally, and that's, as I said, because you kind of lose that differentiation between the cortex and the medullary cavity. So technically, the bones are, if you compare it to somebody else, probably osteopenic, but they just look funny. They just look different to normal. And then subperiosteal bone resorption along these, particularly these radial aspects of the middle and proximal phalanges, second and third. Okay, so that's the classic spot. You should be looking for it. And there's not really a differential for that appearance. That's going to be hyperparathyroidism. Whereas if you've just got acroosteolysis on its own, then there's this pinch foe mnemonic for that. Psoriatic arthritis is definitely worth knowing. So if you saw acroosteolysis and then some joint disease with erosive oligoarthropathy, then you'd be thinking psoriatic arthritis. Thermal injury, frostbite can cause it. This is pretty rare, diabetes causing acroosteolysis. Leprosy these days is pretty rare as well. Scleroderma, severe Raynaud's can cause it. Hyperparathyroidism, as we've seen, and then these are pretty small text kind of things at the end here. The main ones I think you should know about are psoriatic arthritis, scleroderma, and hyperparathyroidism. They're the most likely kind of things that you're going to be shown as a hand radiograph case to come up with a differential. So next case, 5-year-old male, tender over the olecranon after a fall. Here are the images. Who's going to describe this one?
Yeah, I'll have a look. So it's a radiograph of the left elbow of a skeletally immature patient. There were no discrete fracture lines that I could see. However, there is a joint effusion with the presence of anterior and posterior fat pads.
Yeah, the fat pad out the front looks just a little bit prominent, but definitely there's a fat pad out the back, which we shouldn't see normally, so that indicates that there's a joint effusion. I agree. Keep going.
And then, yeah, I'm just drawing some lines. So I'm looking at the anterior humeral line, which looks good right through the capitellum.
Yeah, so if we drew a line down here, that would go through the middle third of the capitellum, so that's not displaced. Keep going.
And then, however, the radiocapitellar line does not intersect with the capitellum. So that's suggestive of a proximal radial dislocation.
Correct, yeah. So if you draw a line, and it's oriented along the radial neck, so if you draw a line along here, it should intersect through the capitellum on all planes, basically. On the lateral here, you can see that is not intersecting with the capitellum, implying that the radial head is more anterior than it should be, so there's an anterior dislocation. And on the AP projection, you can also kind of see that if you draw a line through this radial neck, it's not really going through the middle portion of the capitellum like it should be. It's slightly off, isn't it? Great, so that one is a radial head dislocation.
Yep.
What needs to be done for that?
So it needs sort of immediate remanipulation or a closed reduction to get it back in place. I guess we'd also want to just make sure there's no fracture further down the shafts of the ulna, or like the diaphysis of the ulna or the radius.
Yeah. So if there was a fracture of the diaphysis of the ulna, in this case, what would this be termed, this injury?
So excuse my pronunciation, but Montagia.
Yeah, sure. That's probably better than my pronunciation.
So yeah, it would, so that would be consistent with a Montagia sort of fracture dislocation.
Yeah.
If that was the case.
Yeah. So in Montagia fracture, you get a fracture dislocation, you get an ulnar shaft fracture, and you get a dislocation of the proximal radial ulnar joint. And what's the other forearm fracture dislocation that's commonly referred to?
So the other one is a Galeazzi, which is the opposite, so a mid-diaphyseal radial fracture with a distal ulnar dislocation.
Great. Alrighty. Cool. And I think that's all to really discuss on this one. So yeah, just make sure on your pediatric films you're always looking for joint effusion. As soon as you see a joint effusion, you're thinking that there is an injury. Most commonly it's a supracondylar fracture, an occult one if you can't see one. So that would have been, if you didn't see a radial head dislocation, that would be the thing to say in your report. I suspect there might be an occult supracondylar fracture. Look at that anterior humeral line. If there is a supracondylar fracture, that capitellum is usually displaced posteriorly. And always look at that radiocapitellar line. It should intersect through the capitellum. If it doesn't, then you've probably got a radial head subluxation or dislocation. And yeah, closed reduction is often all this will require. So there's just an illustration of the normal radiocapitellar line intersecting the mid-capitellum, and there it is with the dislocation as we saw in our case. All right, next case, female patient with a traumatic hand injury. Someone can tell me about this one.
Yeah, certainly. I'll have a look. So we're looking at an AP radiograph of the right hand. I can't really see any acute fractures. Otherwise, all joints are relatively well aligned. I am noticing an abnormality with the carpal bones, though. So there appears to be a lunar-triquetral coalition.
Yep.
And there's also, I think, a fusion of the capitate and the lunate, capitate and the hamate bone as well.
Yeah, capitate and the hamate, correct. So this is the capitate and hamate. So what do you think this means, if anything?
It probably... I assume that this could be just a regular developmental abnormality. But given the patient's presented with possible pain, you can get, I think, chronic pain that arises from this sort of carpal bone abnormality as well.
Yeah, you could get some biomechanical differences in patients with coalitions like this that may cause an arthropathy in the wrist. Although it looks pretty good, doesn't it? There's not really any joint space narrowing or osteophyte formation or sclerosis in there. This is just a case of an incidental coalition. The most common carpal coalition that you're going to see is that lunate triquetral, so this one, and then the second most common is going to be that capitate hamate coalition. We usually prefer the term coalition rather than fusion because developmentally it's actually more of a failure of segmentation of those carpals apart rather than actually a fusion of them together. So the preferred term is, carpal coalition. So just a nice little incidental finding that you could get as an exam case. But I agree, there's no fracture or dislocation in this case. Next case is a 55-year-old male with declining hand function and increasing deformity. I'll stick this on full screen so someone can have a look.
Okay, so we have frontal radiograph of both hands. There are multiple areas of degenerative arthropathy, including the left third and fifth proximal interphalangeal joints, the right fourth interphalangeal joint, They all show joint narrowing and bony erosion. The first left metacarpophalangeal joint has some punched out bony lesions associated with it, as well as a surrounding density at the joint. I think that is also present on the right first metacarpophalangeal joint to a lesser extent, and those are likely to represent tophi. So to summarize, I would say it's bilateral gouty arthropathy.
Yeah, excellent.
And there's also some similar erosions in the carpal bones as well.
Yeah, great. So this is chronic gout arthropathy of the hands. You've described most of the key kind of features here. It's kind of oligoarticular in that some joints are severely affected, whereas other joints look normal. And that's kind of in contradistinction to that osteoarthritis one we saw earlier, where all of the joints were kind of involved, a little bit to varying degrees, but all of them were involved. Whereas this one, you've got completely normal joints and then some that are completely destroyed through the process. But you can see that the joint space is preserved here. You've got these erosions which are punched out, as you said, so really well defined with a sclerotic margin to them. We often call this little edge that's hanging here called an overhanging edge, which is very characteristic of gout. And the location of the erosions, while some of these are periarticular, the juxta-articular location is the one that's kind of typical. So kind of just away from the actual joint, so more where the capsule's already inserted, and then you've got these juxta-articular erosions. And as you said, this high density swelling in the soft tissues adjacent to it, which is the actual deposition of urate that you're seeing as a tophus. Carpal bone involvement is very, very common, and same when you're looking at the midfoot involvement of the tarsal bone. So look back here, you'll always see these kind of punched out erosions sitting in the carpus as well. It just helps you confirm that this is gout. Some of the other features, the bony density is preserved as opposed to rheumatoid arthritis, where you get this periarticular osteopenia. This is very much the periarticular tissues have got preserved bone density, so there's no osteopenia. I've got a slide here. This is obviously a foot rather than a hand, but you've got really big, obvious tophi here. You've got that classic punched out erosion with a sclerotic margin to it. Rheumatoid arthritis tends to have an erosion that's ill-defined, doesn't really have a sclerotic margin, just has a lucent kind of margin. You can't really draw a pencil around the edge of it. It's got a classic overhanging edge here as well. And you can see the actual joint space itself is quite preserved here, so it's really a juxta-articular process primarily. So I've just documented some of those here. So rat bite erosions, you might hear that term, juxta-articular, overhanging edge, sclerotic margin to the erosions, preserved bone density, joint space maintained, and then the high density swelling, which is the tophi. Excellent. Okay, next case, so minimal trauma with pain on movement of the little finger, and this is a 35-year-old female. Here is the frontal and lateral radiographs.
Yep, so frontal and lateral radiograph of the left fifth finger demonstrates a expansile bony lesion in the proximal phalanx, proximal part of the proximal phalanx. It's got a fairly narrow zone of transition, and it does seem to be involving the cortex on the ulnar side. Mm-hmm. It's a fairly typical location for an enchondroma in the hand, and the cortical involvement probably represents a small pathological fracture from the trauma, though without that a differential would be a chondrosarcoma, which can present with pain as well and may look similar.
Yeah, good. So I don't know how much we want to go into chondrosarcoma in this kind of case, because most of the time these are going to be, non-aggressive enchondromas with a pathological fracture just following some minor trauma. As you said, it's got that lucent appearance to it. It's a bit expansile. It's causing what we call endosteal scalloping, so it's kind of thinning the cortex a little bit, which is typical of enchondromas. It's got a narrow zone of transition, consistent with being a non-aggressive lesion. And as you said, it's a very common location. I think I've got a picture here. So the proximal phalanges, 40 to 50% of solitary enchondromas in the hand occur in this region, although you see them quite often in the metacarpals as well, often in the middle phalanges, quite rare in the distal phalanges and the carpals. But yeah, that's a pretty classic fifth proximal phalanx base expansile lucent lesion. Elsewhere in the body, they often have chondroid-type calcifications in the center of them, these little rings and arcs of calcium, whereas in the hand, they can, but often they don't. Often they're just a very lucent expansile lesion. Okay, so don't be put off calling an enchondroma in the hand if it's just lucent. If there's no calcifications, it's still going to be an enchondroma. It's by far and away the most common lucent lesion of the hand. There's a couple of multiple enchondroma kind of syndromes that occur. These are classic kind of exam fodder for the second part exams. So if you have multiple enchondromas called enchondromatosis, this is Ollier's disease, and you can see it looks more like a dysplasia, doesn't it? Because it involves almost every single bone, and because it's so extensive, you quite often confuse it for some other skeletal dysplasias. So these are multiple enchondromas. Ollier's disease, it doesn't just involve the hands, it involves lots of other areas as well. And then if you have multiple enchondromas and associated soft tissue hemangiomas, you can see these little phleboliths, these little calcifications within the soft tissues, and you can see the soft tissues here are lobulated. So there's actual hemangiomas in the soft tissues here, and that is known as Maffucci syndrome. Okay, so if you don't see any phleboliths or swelling in the soft tissues, then call it Ollier's disease. If you do see those little phleboliths in the soft tissues and lobulated soft tissues, then it's more likely to be Maffucci syndrome.